Hello, I'm Jeffrey Lieberman, Chair of Psychiatry at Columbia University, and I'm the host of this program on the mental health effects of the COVID-19 pandemic. The organizers of South by Southwest felt that it was essential that this topic be included in the conference because everyone agrees that the second shoe that's going to drop in this crisis and persist long after the virus is contained and we've achieved herd immunity will be the mental health consequences of what we've gone through. However, nothing as yet is being done about it, even though there's much talk about it. For most everyone alive today, the COVID-19 pandemic is an unprecedented experience. We've all lived through natural and human-made disasters, to be sure, but this is the mother or the father of all disasters. And that's because prior disasters, whether it was the 9/11 terrorist attack on the World Trade Center and Pentagon, or the Indian Ocean earthquake and tsunami that followed in 2004, or Hurricane Katrina in 2005 that devastated New Orleans and the Gulf Coast, they were nowhere near as widespread or enduring as the COVID pandemic. To try to place this in historical context, I asked my 96-year-old mother, God bless her, what in her lifetime did this most represent or resemble? And she thought for a minute and said, well, it wasn't the polio epidemic, that was seasonal and it wasn't as prevalent. And it wasn't even World War II, which hung over us for all that 4 or 5 years, but it didn't disrupt our lives so much. So I believe it most resembles the Great Depression, in which we had an acute shock of a stock market crash, followed by years of economic devastation and despair. Now, we know that the Great Depression produced a generation that bore its effects. So similarly, all of us will be part of what will come to be known as the COVID generation. Now, it's not to say that we're all going to be affected in the same way. You know, some of us will have only been inconvenienced and annoyed for a year, while others will be forever changed by the experience. And some will have been injured or irreparably impaired by the experience. And tragically, too many of us will have died as a result of the COVID pandemic. Now, this impact may come either through the direct effects of the virus infection and their antibodies on the brain, or the environmental and social or economic consequences of the pandemic. George Bush famously said, George W. Bush, that is, fool me once, shame on you. Fool me twice, shame on me. Now, that's to say that we were surprised and taken off guard by the COVID pandemic, but we know that the psychological aftermath is coming, yet we haven't done anything to prepare ourselves to prevent it. So to enlighten you, I'm joined by 3 distinguished colleagues who will review the current understanding of what's happening to us, what lies ahead, and what we can do to mitigate or even prevent the psychological consequences. Dr. Cristiane Duarte is a professor of psychiatry and epidemiology at Columbia University and the director of the Intergenerational Psychiatry Center. She is an expert in children's mental health and disaster psychiatry. Dr. Patrice Harris is a child psychiatrist who formerly served as the director of the Department of Health Services of Fulton County in Atlanta, Georgia, and is the immediate past president of the American Medical Association and an expert in health equity, social justice, and racial bias. Linda Rosenberg has a master's degree in social work and is a professor of psychiatry at Columbia University. She previously served as the Deputy Commissioner of Mental Health for New York State and is the immediate past president and CEO of the National Council of Behavioral Health, which is the largest organization of community-based mental health programs in the country. So let's begin with you, Cristiane. Let me ask you, we know there's going to be a psychological price to pay for the pandemic, and we want to be the canary in the coal mine warning the country. But on the other hand, we don't want to be Chicken Little or the boy who cries wolf and be alarmist. You've studied many disasters in the past, and most recently the effects of Hurricane Maria in 2017, which devastated the island of Puerto Rico. What have we learned from these, and can this help us to know what to expect?
All that we know about disasters and mass traumatic events to this point is, as you mentioned, limited to some geographic and temporarily limited events. So nothing has been, as you mentioned, as prolonged and universal as the COVID-19 pandemic. What I propose here is that we think about children. That's what I do for a living. So children have been called by some the hidden victims of the COVID-19 pandemic, as they are in this paradoxical place where they are the ones least likely to being seriously sick because of the virus, but also the group for which we expect to have the largest mental health effects. And why would that be the case? So if we think about 2020, what we saw was a range of adverse experiences becoming part of the lives of children. And those experiences, we know that they have a really powerful effect on the future risk of mental health problems and also health problems. Some of those problems, if we want to think about them, is first of all, children have experienced the loss of their parents and family members, particularly children of racial ethnic minority groups. We've seen that. We have seen parents that are parenting without any usual of the supports that they usually have access to. And describing that as an extremely distressful experience, particularly for mothers. And we know from research that we did prior to, after other disasters, that the distressful experiences of parents can have a big impact on child mental health. We learned that after 9/11, there are studies about Holocaust survivors that also found the same. We also expect an increase in other consequences of unemployment and parental distress, such as domestic violence or child maltreatment. We actually have seen a decrease in the reports of maltreatment in New York City in the past year that was down to 50% of what we expected in times before the pandemic. So we are also concerned about abuse that is not being reported. And adding to all of that, we also know now that 1 in 4 US children are experiencing food insecurity, which is something that has clear consequences for the health of children, but also for mental health. We know that as well. And so these are all risks that we know about, and we know how deleterious they can be for child mental health. But on top of all of this, we have a social isolation that is occurring at levels that we have never seen before, and it's hard to predict what consequence they may have. So what can we do? I think is the next question. We know that the reopening of schools, and we just got last week new CDC guidelines about how that could happen, that reopening could partially address the several issues that we're concerned about, including parental distress and at some level food insufficiency as well. But my thinking is, as we are packing up our prevention bags, right? So as we put in the masks and physical distance instructions, COVID testing, and et cetera, should we also be thinking about adding school-based mental health prevention strategies? You know, we know a few things. Our arsenal includes preventive evidence-based strategies that can focus, for example, on strengthening peer relations, bullying prevention. And we know that those actions, they do have an impact on reducing the stress among students, reducing age of onset of alcohol use or drug use, and that can be have an impact on this, what we are expecting. So I do encourage ourselves to think seriously if we could have here our own mental health vaccine that, if can be delivered in our schools, could reach students from various socioeconomic, racial, and ethnic groups in a more equal way. And then we would have a chance to getting ahead of this tsunami.
The COVID pandemic hasn't affected everybody equally, and it's disproportionately affected our population based on racial, ethnic, and socioeconomic factors. And this pertains from everything from infection rates to mortality, access to care, and now the vaccines. Patrice, from your perspective, what are the reasons for this, and how can we fix these problems? And what are the ramifications for these disproportionate effects and whatever we can do to mitigate them in terms of the mental health consequences that we foresee?
Jeff, very important questions as we think through our planning for the next phase of this pandemic. But clearly, COVID-19 has amplified several fault lines in our community, right? The lack of the public health infrastructure, as you and I well know, and all of us on this panel today, the lack of a mental health infrastructure. And certainly the elevation of centuries of structural and systemic policies and practices that have led to the social determinants of health and ultimately have resulted in health inequities and disparities. Now, certainly these inequities and disparities are not new. They've been documented before, but as I've been saying in several panels, now, because we are all sort of focused on the pandemic and the sequelae of the pandemic, we cannot look away. A couple of things I want to say is we have to also be clear about the fact that these inequities are produced, they're not random, and they are most certainly avoidable. And so as we really look upstream, again, we need to look at structural racism, past discriminatory policies. We need to look at housing practices. We need to look at all of these issues as far as we can upstream, which then lead to issues around poverty, where people live, work, and play, whether or not folks live in food deserts. And then when we really think about the COVID-19 pandemic, and we know that Black and Brown communities have been disproportionately impacted, we can look at the now, right? Most likely to be essential workers, right? Least likely to be able to work from home, having to use public transportation, living in multi-generational families, unable to physically distance at home, even if they are able to do that at work. And finally, least likely to have health insurance. And so it is all of these factors from those upstream to those downstream that have led to this disproportionate impact. Now, we all know that everyone has been affected regarding the psychological and the mental health effects of COVID, and no one has been spared. I do like the fact that we are highlighting children, and I love that Christiane highlighted children because we have seen pre-COVID an increase in anxiety, increase in reports of depressed mood, increase in reports of suicide attempts, particularly in young Black men. So we've seen all of these increase pre-COVID, and certainly the isolation, the disruption, the grief, and the lack of access to health care have led to, in some ways, disproportionate impact on Black and Brown communities. And Jeff, context is always important. I really like the way the World Health Organization talks about these parallel crises, of course, the pandemic, but also the mental health effects of COVID. But I think we also have to make sure we are thinking about other traumatic events that have happened this summer when it comes to Black and Brown communities. We've seen police brutality, right? We've seen racial injustice. We've seen, unfortunately, a climate where we have not had reasoned political discourse. And I can tell you that so many of my colleagues, friends, and patients from Black and Brown communities feel unsafe, further resulting in trauma and a critical need for us to talk about and address the mental health effects of COVID-19. But right now, we should be thinking and planning as we are amplifying in this conversation about what to do. We cannot wait. It is urgent. We have to meet the moment right now and think about the longer term mental health effects of COVID-19 and trauma and all the other injustices that Black and Brown communities are experiencing.
So Linda, Christiane and Patrice have outlined the fact that there's a whole range of effects that are occurring in the context of the COVID pandemic and are going to persist in the aftermath, and they're disproportionately affecting different groups, children, communities of color, individuals that have been disadvantaged in terms of healthcare historically and now are disadvantaged to a much more acute degree. And then that even extends to not just the healthcare for if you get the COVID infection, but also access to the vaccine and access to treatment for other conditions thereafter. Given our healthcare system wasn't any great shakes to begin with, our mental health care system, which you oversaw for those 10 years you were at the National Council, how do we begin to address it given the expectation of a heightened need? And also what kind of special initiatives could be envisioned and would be recommended for the purposes of addressing these groups that are in greatest need and have historically not been receiving the necessary attention?
So, I'm an optimist by nature, so I'm also going to look a little bit at the opportunities we have and some of the work that is already going on to take advantage of those opportunities. But, I think Dr. Harris laid out very well what we've all experienced, including a political insurrection. And so what we have now is survey data, and the survey data shows that there is increased distress since the pandemic, since we've witnessed the murders of Black Americans, since we've seen a political insurrection and the economic downturn. The distress is particularly high, interestingly, among youth, teenagers, and essential workers. And many essential workers are people of color. But we know, and the only thing we have is to look at past disasters, and Dr. Duarte shared some of that with us, that most people are resilient, and that after a number of months, people go back to the functioning they had before. This, in fact, may be different in that it is a worldwide pandemic, but we do expect most people to do well, and we know what will help those people. Information, accurate information, person-to-person support, and resources around mindfulness. Here at Columbia, we've just started an initiative with libraries to get that information out to communities. We have a hotline that the state is running. I just saw the same thing in North Carolina. So people are getting lots of information that for many Americans should be helpful. But we know that the closer you are to the distress, which means you were ill, someone you know was ill, you lost a loved one, you have a history of personal trauma, or you have a psychiatric disorder, that for you, this is going to be an increasingly difficult time and already is difficult. And what communities are looking at is what we all want when we need help. 24/7 access via email, phone, or text. We want science-based and skilled people to talk to. And we want to be able to close the loop. So when we're working with people, because we are in trouble, that we look with them at what are those outcomes for us? And how do we know we are improving? I think when we look at kids, one of the things that in my talk with communities around the country that we're not looking at closely is the trauma of reentry. Kids have been out of school for a year. They're going to have to go back and sit still, be in a much more structured environment. Any of you who have children or grandchildren know that Zooming and getting up in between and even playing video games while you're Zooming is really very much what's going on out there. So I think because we have built enormous numbers of school-based programs, again, we have a number of them in our local schools in the Columbia area, those programs need to step up and help those schools with what I think will not only be the kind of suffering young children who've lost loved ones have had, but also the hardship for all children, particularly those that have some pre-existing disorders, in getting back into the routine. I think the other thing we haven't talked about enough is addictions. Of the data we do currently have, we know overdoses have increased, and certainly medication-assisted treatment is more available, but what we're beginning to learn is it's necessary but not sufficient, and people need a time and place and a community. We also have a dearth of integrated treatment, not mental health and primary care, but mental health and addictions. And I think we're seeing more and more states do what New York is doing, combining their two state agencies and creating one license and creating opportunities for people to get both treated in one place. And then lastly, in terms of optimism, we have an agreement I've never seen before, certainly among mental health and addiction stakeholders, that what we need is a robust public health infrastructure. We need to eliminate structural racism in our institutions, and we need to deliver mental health support to a frightened and fragile American public. I think that people are agreeing about that. They've even taken a step further. They understand that it's not mental health that's fragmented. It's not even healthcare that's fragmented. It's the world we live in. And you've got to bring people together in collaborations. And I think we're going to see that in the current administration, where there's going to be investment in the safety net and in what I call the political determinants of health. They may be social, but they're also politically determined in terms of what gets paid attention to. I think the other thing that I see all the stakeholder groups agreeing on is that there is a continuum that begins in the community, ends in healthcare, but there are all the places in between that people go to. We find people in where they are in distress, and we've got to start to deliver services in those settings the way we've begun to do it in schools and even in the workplace. And I think the last is, if you take all the national groups, government and not-for-profit and associations, they've come up basically with 8 strategies where there is great agreement of issues we need to address, and now are building tactics around that. So I think, although this is an extraordinarily difficult time, it's also created opportunity to rebuild and to build that we've not had before.
I love your optimism, Linda. Although the way I hear your optimism is that we have an opportunity by virtue of the fact that healthcare and mental health care in particular has receiving greater attention because of the obvious need. What I'm less sort of optimistic about is the fact that there will be actions taken to really address the concerns. But I'd rather be a hopeful optimist than a cynical pessimist. But along those lines, if there's going to be an initiative, public mental health, or just added resources for recommended or prioritized programs to preempt or mitigate the aftermath of the COVID pandemic, given what Christiane has said and Patrice has talked about in terms of vulnerable populations, so youth of certain age groups particularly, communities of color and underserved minority groups historically, is it a situation, and this gets to your politics of determinants of health, are these enough to occasion that whatever initiatives are made target these individuals directly? So Patrice, is this going to run into political headwinds if we say, because of the fact that certain demographic groups were hardest hit and certain age groups are most vulnerable to the consequences, that whatever limited resources we have, they should go to those groups, or they should be targeted to those groups specifically?
Well, let me say that I'm probably a bridge between you and Linda, right? I've been using the term pragmatic optimism. In general, I am an optimist because I think, it's better to choose to go through life being an optimist. But I add the term pragmatic because I agree with you, Jeff. It's going to take action. I think, we are prone to agree on what should be done in this country, but where we get into the difficulties, as you allude to, is how to get there. Now, I have to say that we are having a conversation about equity for the first time, a real conversation. Again, a few of us have been talking about this for years, but the broader conversation around equity is promising. There's potential in that. And so I think if we agree, and I think there's probably an agreement to center equity. And by that, what I mean is that people, communities, as you mentioned, get what they need. I mean, we have to get beyond this, everyone gets the same, or even, we treat everyone the same. No, if we are really centering equity and are true to that, we will have, first of all, the data around these particular communities. And that's been a gap: race, ethnicity, gender, zip code. And then make sure that we tailor our interventions to the community. So this is always a sticking point, Jeff, but I actually am more optimistic than I've been because we are having true, thoughtful conversations around these populations who have heretofore experienced inequities. The other point I will make is the need to invert the burden. We talk about this a lot in a group that I work with here in Atlanta. Our systems of care, not just our health system, but our systems of care, and we know every system from transportation to the built environment to our housing system, all impacts health. It's very difficult to navigate. I don't know about you, but when I've been a patient, I found the healthcare system difficult to navigate, and I'm a physician. So we also need to make sure that as we center equity, and by the way, center mental health, we also have to make sure that the system is easy to navigate and not difficult. So I think, as Linda said, we have folks in the room that are working in concert. We have to be about the business of not only busting silos, but making sure we are integrating services. And from the macro level, we have to make sure we are eliminating those policy disincentives that have heretofore gotten in our way. And I'll finish by saying, again, COVID has forced us to accelerate a lot of these issues. Right now, listen, and I'm sure you all at Columbia have been using telehealth for a while, but we've accelerated that. All of the barriers around opioid use disorder, right? Some of those policy barriers, we were forced in a good way to eliminate those. So again, there's opportunity for us to meet the moment, Jeff. Politics will get in the way, but we'll have to make sure that we are dogged in our determination.
I'd love to be an optimist or even an optimistic pragmatist. I'm trying very hard to hold on to being a realist without becoming a cynic. But before I go to Christiane, Linda, were you going to add something?
Yeah, I just wanted to add one thing. I think in the end, we have to look at communities because it is such a complex world and it is so fragmented, impossible to navigate most systems, actually, and particularly healthcare. We've got to look at localities. And one of the barriers in localities and communities is who's at the table. And, I was talking with the commissioner in North Carolina of behavioral health. One of the things Vic said was when they want to bring organizations to the table, they actually have money to give out. But because they're government, it's an RFP process. Those organizations that are led by Blacks and people of color are not competitive. And those are the kinds of things we have to address, both in the national, political determinants, but we also have to be very conscious of it as we plan and we try to decide what communities need. They need to decide what they need, and they need to be at the table, and we have to make that possible.
Christiane, your comments prompted me to think that although youth are vulnerable, and I know that people that have had teenage children have heard them complain, all my social activities are ruined, and I'm not be able to get my tennis lessons and so forth. But it would seem to me that there's particular age groups that are more fundamentally vulnerable because of these critical stages of cognitive development. How do you understand that?
I think teenagers, because of the whole disruption of the social fabric, if you will, and at a time when the next milestone that we are expecting is that they build these social relationships and get away from their parents, and that is so severely disrupted. I do agree that I expect, strong effects there. But also, it's also a group that we have been working with for a while, and we know we have some measures that we can use and strategies to prevent some of the things that we know that may be coming down the line in relation to onset of substance use, that we know that down the line will become the problems that we want to prevent. So that is the opportunity piece that I think we have in front of us that we can work with right now, and this is important. We also have been thinking a lot, as we put the emphasis less on the individual and more in communities and also on families. That's something that we believe that is going to be really important. It's we've seen that in other disasters, right? When we try to think about the experience of the traumatic event as an individual event, but in this case, more than many other disasters, it's really a familial experience, not only an experience that happens to the community, but actually to families. And so our thinking needs to accompany this different nature of the experiences that we are seeing, and how can we intervene with families and make the life of a family with interventions like Patricia and Linda were referring to, that occur at the community level and are thinking about everything in their lives, their housing, feeding practices, and so many others. So I think that's the challenge that we have in front of us. And can we go to systems that we have in our society that can help us provide more equitable care? And the schools, in that sense, I believe, are really important places for that.
Right. Well, I think, your comment, your answer to my question highlights, the complexity of the issue, which is illustrated in the one slide. Academics can't give any talk without showing a slide. Although, this is something that's affecting the whole country and the whole world, everybody being impacted, it's having these differential effects. And the differential effects are determined by a variety of different elements. So, one is just proximity to the infection in terms of if you've been sick, if you've been in the ICU, if you've had a family member that's died, the demographics of people, youth, elderly, race, ethnicity, the environmental factors, which have to do with rural, urban, which is a lot of is access to care or congregant living. The political status, unfortunately, has figured into this, but most significantly, socioeconomic status, and whether people are living in multifamily homes, they've lost their jobs, or they're doing non-healthcare essential work and have to get out there and expose themselves. And then also the genetic and constitutional factors in terms of pre-existing conditions or vulnerability. So I'd like to ask each of you to sort of speak to the area that you've been most focused on, and I'll take the genetic and constitutional vulnerability one. But maybe starting with you, Patrice.
Well, I have been focused on demographics, but in a broader, I guess maybe demographics and environmental, but certainly in a broader context here, because as we have had conversations about these inequities and the disproportionate burden, and issues have come up around race, and we have certainly needed to have collected data and to disaggregate the data based on race. We have to be clear that it is racism and not race, because particularly early on, there was some blaming going on. Because again, early on, of course, folks that were and still are impacted, certainly the elderly population, but also if you had a pre-existing condition such as hypertension or diabetes or some other medical condition. And there was, conversation that at least I heard, unfortunately, that was based in racism, that talked about blame. and personal responsibility. And I'll just make the broader point that, when we talk about personal responsibility, yes, that goes for everything, but the choices people make are based on the choices that they have. And so context is always important. I gave a sort of TED style talk once about the opioid epidemic, and it was sort of a what if. Each one of us had to answer the question of what if. And my answer was, what if we looked at every public health crisis, and this was pre-COVID, with a lens of context, intellectual honesty, and data. And so I think that as we think about the issues that I have been focused on, which are demographics, but yes, in the service of not checking a box or blaming, but in the service of understanding and in the service of equity and equitable interventions, I think that goes hand in hand within those environmental issues. And again, looking further upstream to practices and policies that have led to the context of environmental determinants, actually political determinants, as Linda said. And of course, understanding of these in the context of race, ethnicity, gender, age, all of these demographic variables, but we have to appreciate them in context.
So really, the COVID pandemic has really just elevated the issues and the questions that have really existed and you've been focused on for a long time, and made them more acute. So therein lies the potential opportunity, but the question is what actions will be taken to try and address those. Linda, which box do you want to take on?
Interesting. I'm not sure about the box, but I think there are two things that I have not heard a lot of discussion of. One of them is end of life and the elderly and what we've learned as a result of this pandemic. Maybe it's because of the stage of life I'm in, I'm closer to it. But the fact that the deaths, and we have a scandal right here in New York around this data of people in nursing homes dying and have been alone, not only when they died, but for a year without visitors. And, we already somehow in the back of our minds knew we had an issue about people and aging and disconnect from family. I think this brought it home, and we're not paying much attention to that and what policies we need to look at around that. The other thing this brought home for me, which I've always known, is the poor and people of color always suffer in every catastrophe to the greatest degree. And the people I know who are the most comfortable financially have actually had a boon. The stock markets continue to go up. They bought houses in the Hamptons and in Florida, and they've enjoyed working from home. So I think there are other things, and how are we going to ask them to contribute in solving some of these problems that they've not experienced? And I don't have answers for these, but I just wanted to bring up those two issues because I think they're part of the fabric of what we see around us.
Yeah, part of the scale of this disaster is the fact not just its longevity and its global reach, but also the fact that it cuts across all dimensions of society and life, as you've been pointing out. So Christiane, I'm not going to ask you not to necessarily focus on the slide that of determinants of risk, but are we overstating the looming crisis that we think is going to persist or occur over the next several years in terms of the psychological and mental health consequences? Are we overstating this, or is the resilience of people and or whatever social programs we have sufficient to mitigate it, or is this something that's going to be an unmitigated continuation of the disaster?
Thanks for this question. So give me a chance to be the optimistic. So I like it. So I hope so. I hope that we will be able also to pay attention to what are the sources of resilience. And as we mentioned here so well, all the opportunities that are coming also with this experience. we, can think about some circumstances or some groups of people or experiences that, as a result of the pandemic, have also brought some. The pandemic has also brought some help for. So we need to be careful, right? So as I was mentioned the other day, there has been reports, for example, after Hurricane Katrina, what we saw was actually there was a national study, big study of the population involved that actually found a decrease in suicide rates. And the explanation was related to what we call post-traumatic growth, where we saw some of this after 9/11 as well, or for some groups of people where, depending on many different circumstances and with adequate support, a traumatic experience can become an opportunity for mobilization of strengths and willingness to grow. Of course, this doesn't happen in a vacuum. That is also needs all the different supports to be in place so that those experiences can be transformed into something positive. And as a society, I think what we hope is that we can provide that scaffolding so that can happen as well. So I think there is hope. There is also a recent paper I was reading showing that during the pandemic, there has been actually a reduction in Google searches about suicide. What does that mean? We don't know yet. But on the other hand, and going then, showing that keeping the optimism may sometimes not be as easy, we have also seen, and there was a publication about what was happening in Maryland, a very steep increase in completed suicides among African Americans during particularly the most acute period of the pandemic between March and May of 2020. So just underscoring that growth and resilience is absolutely possible, but we need to provide the conditions for that. And we need to be absolutely acute and pay a lot of attention to the needs of specific groups that may not have that support, in which it's going to be very unlikely that we're going to see this type of positive outcomes, and we need to work for that to be able to.
Also, the groups, people, rise to the occasion in the face of a crisis and stress. The question is how long can it be sustained? And then what happens in the aftermath when their, kind of adrenaline response has really ended or been exhausted. So, if you're saying, how you see pundits saying the stock market's going to crash or the stock market's going to keep rising, and, they forecast, and then there's the bears and the doomsayers, and then there's the optimists and the bulls. What I'm wondering is that everything that we're discussing suggests that there's going to be a big psychological price to pay. It's going to affect people disproportionately. And among those people in certain demographic groups, certain age groups that are particularly at risk. And the good thing is that we know a lot about who's going to be affected, why they're affected in this way, and therefore what might be done. The question is will there be an initiative and resources mobilized to address this? And that's where my kind of pessimism comes in. So just to try and put this into a question form, what you, Patrice, and Linda, and Christiane have been suggesting could be done to mitigate some of these risks. Is this something that requires being done at the national, federal level, or can it be done more individualistically at local levels or state levels or community levels?
Well, I would liken it to what's been needed since the beginning of this COVID-19 pandemic. We have needed a national strategy. There's no question. And we need resources to come from Congress. There's no question. And then we need support then at the local level, because execution does occur at the local level. And I do want to emphasize something that Linda said. There's a public health aspect to this. And so it's the public health infrastructure and the mental health infrastructure. And it's not just a one size fits all. but we need a national strategy. In fact, I think, Jeff, you and I have mentioned the fact that we really need, someone with mental health expertise, a psychiatrist on the COVID, task force. And there's also a task force. And by the way, I'm very optimistic about the Biden-Harris administration and what they've done so far. And so we want to continue to strengthen that, making sure that there are folks, or at least mental health is centered on the equity task force, because Dr. Marcella Nunez-Smith is leading that. And so that's centering equity. Very glad about that. We need to center mental health on that task force, and we need to center mental health on the COVID-19 task force. So we need that national strategy, resources, and then support for execution, and policy, making sure that we incentivize alignment for this work at the state and local level.
Linda?
I think the only thing I would add to that is that at the state and local level, and at the national level, that whatever we do, both in the policy and practice arena, is based on science. Being at Columbia has pointed out to me the gap, very clear gap, between what we know and what people get when we talk about mental health and addictions and integrated treatment. And I think we need to be careful that although we have alignment among national groups, things don't get politicized with things we like rather than things that science teaches us works. So I think that's what we have to pay attention to.
Christiana, you've already mentioned a couple of things that could be done to address the effects on children in terms of school-based activities or initiatives, and also addressing the context of the family. And are those sort of the main sort of framing principles to initiatives that would reach out to youth?
Yeah, those would be my pick for sure. But I think as a discipline, if psychiatry and public health, if we can also be reminded over the course of this crisis and our future steps, that we have a number of preventive strategies that we can also use, and that would be very appropriate for the moment that we are in right now, and that we use those. So I do think that as mental health professionals, we are very used to treating and not as used to preventing. So, but I would like to take seriously the idea that we can also be thinking with a vaccine mindset, and that would energize all of us and could have really strong impact.
Well, I think, this is a great start in terms of trying to articulate the scope of the problem and framing what approaches can be taken to try and mitigate or even prevent it from being as bad as, I'm worried that it could be. I might just put in a personal plug for the fact that Columbia Psychiatry has already been at work trying to develop this framework of a model of care that could address population-based public mental health needs in the wake of COVID. And in this context, the idea is not just waiting for people to get sick and coming in for care, but for proactively putting resources and initiatives in place that go into the community and address people from the worried well who are inconvenienced and annoyed to those who are really on the precipice of developing a mental disorder, to those who were really in desperate shape and need support, psychological life support, just like you need life support from the respiratory complications of COVID. And the last thing I'll say is that there's no surprise that the three people that are the experts in today's discussion are Patrice, who's a visiting professor at Columbia, Linda, who's a professor, and Christiane, who's a professor. And this is part of the fact that we don't want to hide whatever expertise we have in an ivory tower under a bushel, but want to make sure that it gets out to the public. And I think the opportunity that you optimists, in the face of my realism or cynicism have pointed out is that you never want to miss an opportunity. And one of the silver linings may be that COVID pandemic has presented us with an opportunity both for mental health as well as for social justice and health equity. So I want to thank everybody for their excellent discussion and comments. We could go on for a lot longer, but I want to thank South by Southwest for giving us the platform to have this kind of forum and hopefully to be continued in the future.